Assalamu alaikum. Thank you, Dr. Hind, for the kind introduction. I will be talking about CML management updates beyond second TKI. So as an introduction, now we've reached a stage in CML that patient experience and clinical outcomes has improved significantly, and the life expectancy of CML patients now is almost similar to the general population. So the next phase of management of CML has to be individualized therapy. Optimal treatment management will require the physician to have appropriate treatment selection for patients from the outset, and adherence and compliance of the patient and proper monitoring to facilitate the choice of the right therapy. Physicians need to consider how safely to discontinue after starting the appropriate treatment for the patient, and have to have the equipment, ability, skills of dealing with intolerance and disease progression. So when we get a new CML patients in this study, 50% of patients will have a comorbidity, hypertension in quarter of the patients, cardiovascular disorders in a significant number of patients, diabetes in this study is 10%. Obviously in our population it might be higher than this figure. And you find that in this study, quarter of the patients actually had two morbidities or more. And this, we have to bear this in mind because it will affect the way we manage such patients in terms of intolerance. So this is a quality of life survey in a study using bosutinib. And we as physicians, we try and concentrate on with the patients that we want to achieve an MMR. So what does this produce for the quality of life of the patients? Obviously, the most important thing is emotional well-being, and the emotional well-being produces a medium effect when we tell our patients that you have achieved an MMR, so that patients are usually happy with that. However, when you go to physical improvement, you find that the physical improvement of such patients is very limited and very trivial. So although we have achieved an MMR and we are happy with that as physicians and the patients are happy, however, the patient's physical well-being has not improved by achieving this MMR. This is a survey of quality of life in patients who are going to have treatment-free remission of more than 1,000 patients. And the survey was done in many countries, including the Middle East. It was in Arabic as well. And the outcomes of this survey has shown that when patients want to achieve a TFR, they were asked, why do you want to go through this? And 50% of patients, said they want to get rid of the current side effects. So that's a significant number of patients. Their motivation for TFR is to get rid of the side effects. So in this survey, what are these side effects? And the side effects were given a number of 1 to 5. 5 is a life-changing side effect. And you can see here fatigue, regardless of which TKI is used, fatigue score 3.3. So patients are usually fatigued, and they are more fatigued than actually how we perceive fatigue is. How about muscle soreness and cramping? A significant number as well, saying that they experience this. Disturbed sleep using the therapy. Pain. Remembering things. So these are all things that affect the patient quality of life. And headaches, and even feeling sad is something that patients experience when they are having such medications. These are the side effects the physician usually concentrates on. What does imatinib cause? What does satinib cause? Bosutinib cause? But actually, the profile of side effects are much more than this. There are more things that affect the quality of life of the patient than these side effects that we all know. How about discontinuation of the TKIs? By 2 years of starting a TKI in the decision trial and the NS10D trial, quarter to 30% of patients have actually switched from the primary medication. About 5 years down the line, 40 to 50% of patients have switched from their primary medication. So a significant number of patients will have switched by 5 years. So this is another figure that we have to bear in mind, that switching happens quite a lot in the CML patients for different reasons. So what happens to these patients who switch? So this is a group of patients who had imatinib and dasatinib, and you can see achieving a complete cytogenetic response in this group of patients who had already 2 lines of therapy. Achieving a complete cytogenetic response is not great, ranging between 20 to 30%. This is the group of patients who had imatinib and nilotinib. Again, the complete cytogenetic response is not great in this group of patients. So this is a high-risk group of patients who actually have a difficult disease to treat. How about overall survival of these patients who are switching? So the blue line is post two lines, the red line, orange line is after 3 lines, and the green line is after 4 lines. And if you look at 5 years, the overall survival after 2 TKIs at 5 years, 80% of patients are surviving. After 3 lines is 60% of patients. After 4 lines or more, only 40% will have a long-term survival. So again, the more switching that happens, the more difficult the patients become. Why are patients switching? And in this study, it is showing that intolerance has become the most frequent cause of TKI switching. And this graph is showing the ratios of switching of intolerance compared to resistance. And after second line, 4 out of 5 would switch because of intolerance. So we have a new agent that works in a different way, myristoyl pocket inhibitor, asciminib. The able molecule TKI has got 2 sites, 2 pockets, the ATP binding site and the myristoyl pocket. These sites are sites that inhibit the molecule, the normal molecule. So this is a normal able molecule, and this is the myristoyl moiety of the molecule. And this moiety enters the pocket, and when it enters the pocket, it inhibits the able gene. So this is what happens in a normal able gene. What happens in a CML patients is that when the translocation occurs, instead of the myristoyl moiety being there, it is replaced with the BCR moiety, which is, as you can see, its structure is bigger in size, and it can't enter into the myristoyl pocket anymore. So the molecule becomes active most of the time. So asciminib binds to the myristoyl pocket and inhibiting the molecule, the able gene. This is the selectivity, the TKI selectivity of different TKIs that we have at the moment. The less sites it inhibits, the less the side effects. So let's look at the BCR-ABL specificity of each of the TKIs that we have. This is the sensitivity or the concentration of the TKI, and the red dots are the leukemia cells, and the blue dots are normal cells. So the more the distance between the CML cells and the normal cells, the less the side effects, because then the drug does not inhibit the normal cells. So if you look at imatinib, you can see that there is overlap between the red dots and the blue dots. So inhibiting imatinib, when it inhibits leukemia cells, it also inhibits normal cells, so then there is more side effects. However, the distance between the asciminib and the normal cells is greater, telling us that there is a larger safety profile compared to the current TKIs that we have. And this has been shown clinically. If you look at the most recent TKI use and the median time on it, compared to asciminib, you can see the difference that the median time on the most recent TKI is 1.2 years compared to 5.9 years in the asciminib. And after 3 TKIs, again, the median time is longer with asciminib. So the tolerance of asciminib, what one can deduce from this, the tolerance to asciminib is compared to other TKIs is better tolerated. This is in the phase 3 trial showing that asciminib side effects are less than the bosutinib, which was used as a comparator in this trial. How about the quality of life? We spoke about the quality of life. And in the phase 3 trial, if the chart goes to the left, then the quality of life has improved after the switch. And you can see here the side effects that have been looked at in the trial, and all the side effects that we spoke about, like the pain, the lack of sleep, lack of appetite, the feelings of sadness is there. And you can see the green bars reflect the asciminib, and all the bars are directing towards the negative side, which means that they've improved and they have been reduced after the switch, compared to bosutinib, where some have improved, some quality of life has improved, but some have not improved. So again, showing the tolerance of the medication. How about the efficacy? Do we reduce the efficacy of the medication if we switch? And you can see the primary endpoint has been achieved. There is a 12.2% MMR achievement difference and bosutinib. And at the end, in ASH 2023, an update was published, which has shown that the MMR achievement has even increased more to 23% difference between asciminib and bosutinib. How about time to treatment failure? Again, the time to treatment failure, asciminib, 50% of patients did not require any change in medication, while almost 90% of the bosutinib patients required a change in their medication. So significant difference between the two in terms of time to treatment failure compared to the two arms. How about the 3 months ABL transcription level difference? And you can see that to achieve this PCR ABL marker for efficacy, you can see that there is a difference between asciminib and the other TKIs. Almost 47% of patients achieve MMR3 after starting it. MMR2, 84% of patients, and less than 10% is 92% of the patients achieve that marker of efficacy. So it's quite an efficacious medication in terms of achieving these levels compared to the rest. So in summary, we are entering a new era of CML therapy. Novel agent asciminib has a novel mechanism of action which has the potential of transforming the therapy of CML. It has a favorable side effect profile compared to the others and similar efficacy. It's highly efficacious due to its unique site of inhibition. And now we have, as hematologists, we have to think in a different way. Those of us who treat Hodgkin's lymphoma have gone through this before, is that when you achieve highly efficacious therapy levels, then the emphasis becomes on improving the quality of life. In addition to keeping the efficacy that you have to think about what are the means through which you can achieve a better quality of life for our patients. And doing this and having the skills of being able to switch appropriately with new therapies, I think is something that we all have to think about for the future benefit of our patients. And with this, I end my talk. Thank you for listening.